more attuned to that, then by the time they get to us, there's already some suspicion. Usually, I mean, we're not the front line. ER doctors and nurses are the front line, and that's usually where they're coming in from. Even if they're being admitted, the charge nurse on the floor, they're going to have some suspicion. So a lot of times it's not up to us to make that call one way or the other that I suspect this. It's been handled probably before they get to us. But just in case, just to be aware. So what are you supposed to do as a person taking the images? Observe the patient, take a history from the parent, and then observe any superficial signs of of anything on the body that may lead you to suspecting. You know, I take it back. I think I did have one suspicion, and it was a fracture, and I can't remember where it was, and it was an ER patient, and I showed the image to the radiologist, and that's what we had to do back then for our ER cases to get a stat reading. We would literally take the film to the radiologist. Here, this is from ER. This is a 5-year-old patient, broken forearm, anyway. And so the doctor suspected something, so he made me go back and take the other arm and both legs, I think a lateral skull, just to see if there were any other signs of fractures. So it's something that a radiologist can do. As a doctor, they can, request more x-rays to look for any previous fracture. Doesn't mean that that was child abuse by any means, but they have that capability of doing that if they think something's going on. And then, so again, go into your radiologist or your supervisor, and then they're the ones that would be contacting law enforcement, social services, or whatever, if that's what. And that's what I'm saying. Some disease processes can mimic, child abuse. Just because they have multiple fractures, maybe they have that disease where they can get they fractured easy. So any disease process may cause that. So that's why you have to be careful. What I found this from a conference. This is not in your textbook, and this your reading assignment is in Bontrager's again. So this is not in Bontrager's, but I got this from a pediatric conference I went to. So a broken leg in a child who hasn't learned to walk yet. Doesn't mean that it was child abuse, but this would, lead to suspicion. Multiple burns or abrasion, degree of bruising is greater than expected for the activity level of that child, a broken rib, fractures of differing ages, and that's what I'm talking about. They can go, every time there's a fracture, you can tell there's been a previous fracture because you get that bone formation, what I call callus formation, of where the bone was broken and then some bone growth over that, so they can tell if a bone's been broken or not. This last one is interesting. I've only had one experience with this, and this is from a friend. Pancreatitis or pancreatic injury. So my friend has a daughter. She still has a daughter, but when her daughter was young, she had a lot of epigastric pain, just debilitating, and went through hospitals and tests trying to figure out what was causing, this pain. And one doctor thought it was pancreatitis and called my friend into the office and wanted to know basically what was going on. And I'm thinking, pancreatitis, well, in a young person, in a not pediatric young, but a young, I don't know, 10, 12, 13, a pediatric patient that has pancreatitis is usually due to a blow to the abdominal area. Pancreatitis is not normal for a young person. It's for an older person.
So it's just like severe blunt trauma.
So yes, and so the doctor wanted to talk to, the mom to see what was going on. Now this child was in dance and cheerleading and, getting thrown up, cheerleading and all that sort of thing, and even in dance. So, I don't know, but she was a little upset. The mom was upset, but that's what the doctors have to do, figure it out. So those are some of the things. And again, it doesn't have to be physical abuse. It can be, and we've heard these stories, unfortunately, on TV, neglect, sexual abuse, psychological maltreatment, medical neglect, not causing the problem, but not getting the problem treated. And so there's a big variety. So that's, you know, again, luckily don't have a lot of experience in this other than what I've researched. And I think as you've gone through your positioning, there are certain fractures that can occur from grabbing and pulling the child. You know, when you grab their arm and, grabbing the arm and yanking the child towards you gives that spiral fracture. So there are certain fractures that, not that every spiral fracture is a child abuse fracture kind of thing, but there are certain fractures that they can look at that may lead to suspicion. So again, rib fractures, it says the classic is metaphyseal lesions, breaking off, again from grabbing, shaking, neck fractures from shaking, that sort of thing. So again, basically what I want you to take away from this is, what are you going to do if you suspect, because that's all it's ever going to be, is if you suspect child abuse, to report it. Who is your go-to person? Either your supervisor or to, a radiologist on site. And that's their decision to make and to call and to, tell you what to do, what they want done at that point. Radiologists may come in and want to talk to the parent. I tell you, they do this at school. I had a student who got called in, and for her child, he had blood in his ear. Wasn't draining blood, but had some blood in his ear. And the teacher asked the child, what happened? Daddy hit him. And so the school called the police and arrested the father, released him, and then they took the children away until they went through all this education and jumped through hoops, and she was a wreck. And her explanation to me was that the dad was in construction, they were doing their house. Construction everywhere. The child wasn't supposed to run in this area because of the planks and the nails and whatever they had. The child ran over there and the dad hit him. It's like, no, I told you. I'm not saying that's right, but it wasn't, taking cigarettes and burning them into their arm. But it might as well have been. So this is taken very seriously. They react very quickly, social workers, law enforcement, whoever, to protect the child. And ultimately, it's all about the child. And until they know for sure and have done everything to make sure the child is secure in their home. So that's why I say it's always a suspicion. You can never say this is exactly what happened, or, So just, if you suspect that, report that. And I think the test question is, who do you report to, supervisor or radiologist? Okay, so what do we have to deal with when we're, yes?
So really quick, if you do have a kid, you're laying them down for like a chest x-ray and you notice blood in their ear, would you ask the kid what happened in front of the parents, or do you just make a mental note, I suspect?
No, personally me, I would ask.
Yeah, okay.
I would ask, and then see what kind of reaction you get. Oh, yeah, he just had, his ear lanced, or the doctor, did this. Or, the parent gets all nervous and just ask. And then if they can't answer, won't answer, whatever, then and you feel uncomfortable, then report that. So that's what the teacher did. And sure enough, the child was hit. So obviously hard enough to cause bleeding. So that's what I would do. But again, ask at your facility what your protocols are. So what are some things that you need? This was never my patient. How nice. Good communication is important. Communicating again with the parent and the child. And immobilization, we don't restrain. our children, our pediatric patients, we immobilize them only during the time of the exam. So let me go back to the Pigastat that you used. Did you use the Pigastat, take the image, and then take the child out afterwards, or did we leave the child in there for a little while?
They did for a little while.
Okay.
Yeah.
Yeah, that's what I want to do too. It depends. I mean, was the baby crying?
Yeah.
Okay, and you know what? We want them to cry
Yeah.
because we want their lungs filled with air. So when they take in a breath to scream, then we take it. So whatever restraint, immobilization device that we're using, the way to properly do it, although it's going to go against every atom in their body to do so, you restrain them. Did I say that again? Immobilize them, take the image, and then release them. And then check your images, make sure, and then if you need to repeat one, put them back in. That is, at some point you're getting into restraints as opposed to immobilization. Typically they're crying, so if they're taken out, maybe they'll stop crying. But you are able to check your images. See, I had to develop. So we would take the child out, and then if I had to repeat it, then we had to start all over again. So it's nice to be able to check your images digitally. How long does that take? And then know if you need to make an adjustment real quick from their original position. So, and then after that, take them out of whatever you're using, whether it's sandbags or tape or whatever. And of course, our short exposure times, as we use with most adults, our short exposure times are really going to be our savior here. So the biggest enemy of detail is motion. So again, our short exposure times, they can't always follow our instructions, so you have to coordinate their breathing with your exposure, and just to make sure mom and dad know. Again, the Pigastat, it looks horrible. Just make sure the parents know, or whoever's bringing the child know, that this is not hurting the child, this is just holding them still. Holding them still so that I don't have to repeat the x-ray.
Mm-hmm.
And guess what? They'll help you put the child in there. They don't want any extra exposure than what you're doing anyway. So a lot of times they'll cooperate with you. Here's some different immobilization devices. So let me know if you have these at your hospital. Here's the Hammond board. I've seen this spelled a couple of different ways. Here is just a platform with a plexiglass, our favorite Velcro straps, securing the arms and the lower body, maybe for a chest x-ray. So here's your AP chest x-ray with your image receptor underneath, and then here's a cross table. You can, with a child like this, you know that they're not going to be rotated. You're going to get excellent images, and they're very secure. And see the baby crying, that's what we want. One time I had a child in a, see this is Cam M, and then this is, I think it's Tamem. Like,
Tame them, huh?
okay, so I think that's the way it's supposed to be, not the way it seems.
Remember the brand.
Yeah. Here's pediatric chairs sometimes where you can slide the image receptor back behind them and use it. This would not be appropriate, right? If you had a child coming in wearing something like this, you'd want to change them out. We'll talk about prep in a minute, but just looking at this picture. So here's a pediatric poser chair. I just love these names. Here's my favorite, the Pigastat. This can be used up to 2 years old, so it's very limited in its use. And if I ask you that question, Merrill's other textbooks state 3, and Bonfieur contradicts himself with 4. Later on, at one point we read 2, and at one point further you'll read 4. So let's stick with 2, is more closer to the truth. And it all depends on the size of the patient. But just to kind of give you an idea of who this would be used for. So I love this. You have this seat. You can't, it's A right here. It's like a little bicycle seat. You know what a little bicycle seat, and they sit down in it, and their legs will come underneath the level of this table. So they're sitting on this little bicycle seat, arms are brought up, and then there's 2 pieces of semicircle plexiglass that encase each side of the pediatric patient, so their face is not being covered. Okay, and then there's a gap in the back too. And then there's a little strap with like a belt buckle that you can bring across that holds and secures those two plexiglass pieces to hold the child straight. And so what's nice about it, here's the image receptor. There's a place right here where you can put an image receptor or even put them up against the wall unit. And then you take the PA, they're nice and straight, the arms up above the head, pulls the scapula out just like we would have them roll their shoulder forward. And then get them nice and straight. And then take the PA and then
Turn them.
this turns so that they're like this, and then you can turn them to where they're like this. And it's great. You get a nice straight lateral, and they're immobilized. They don't like it, which is a good thing, and you can tell the parents we want them to cry, so it's okay. I had only once, had a child not cry. So the little child's little plexiglass is like this, and the child's just looking at me. I'm like, cry. So I'm like, come on, cry.
You're like,
boo. It's like, come on. It's like the one child that, doesn't cry with me, I want him to cry now. So here's the Positot. Okay, tell me that's not Chucky. That is so Chucky. Anyway, Positot. I've never seen this one. Again, using Velcro straps, and this child is like, yeah, look, he's just suspended in the air. I don't know about this one, but not my favorite, but Positot. So again, these names. Oh, here is another one. So the child can be upright or laid flat. They're on wheels and they're pretty secure. Same thing about the Pigastat. It's on 4 wheels. I've never seen one turn over, but sometimes those pediatric patients, their little legs are just kicking, and so I think, I'm always worried that it would tip over, and even if it did tip over, I think they'd be braced enough to where it wouldn't hurt them, but who wants to find out? So if the parent wants to stay in the room, I usually have them put on a lead apron and stand close to the Pigastat. Close to, but not at the Pigastat. You're collimating, so you're not going to have a lot of exposure, but just for safety reasons. Here's some other immobilization devices. These are some, here it says a hand and a foot immobilizer. So these are some sponges to, bring the hands out. And then I call it visqueen, plastic types that doesn't secure. It helps the child hold still. Sometimes they try to cooperate with you to hold still, but they just can't hold still. And so it's just not their nature. So if a child did not want to have their hand x-rayed, they could easily pull it out of here. So this is not an immobilization device. It is kind of, but it doesn't secure them if they don't want it. We've seen some of these before. The hugger, look at that. Little sponge, again with Velcro straps. The infantainer, like container, the infantainer. Restrainer, I don't know. I just think it's cute. So again, just another device where you can do, again, most of these are for your PA and lateral chest x-rays, which is what we typically do. Here's a pediatric chair. Here's a child who can cooperate. They may not be big enough to stand up at the wall unit, but they can sit at the end of the table and again with the image receptor. We're going to show these again a little bit later. These I've used before and they are very helpful. So probably not so much anymore, but I did a lot of skull work and a lot of skull work on pediatric patients. And so typically I would just put on a lead apron and hold the child. You get 2 big, thick pieces of sponge, put your lead gloves on, your lead apron, the child's head is here, and you get those 2 big sponges and you can push them up against the child's head, okay, and push pretty hard without hurting, and it keeps your hand away. You don't want your hands, especially leaded gloves, in the image. So it keeps your hands out of the way, you can push hard, and you can angle the child's head how you want, and then have somebody make the exposure. This is kind of the same thing. This part right here is a sponge. Okay, this is a weight. So rather than me holding it, and they're pretty heavy, I can only pick up one at a time and use it. So it's pretty heavy to keep the patient's head still. Now, I don't know what this picture's about. First of all, I don't know what that is, if that's visqueen or whatever. nothing's going to be covering the child's face. So I don't know why that's there. It's more like this. This is nothing. The only way you could use this is if you got your lead gloves on and used it like that. The child can, if they are fighting you, they can turn their head easily, or even if they're just not fighting you, but they, can't hold. Can you imagine? Tuck your chin down and hold your head still to a child. So typically, maybe this might help again. Sandbags are okay to use, but they can't be in the image. We know that now as an adult. You can use it, if you're doing a hand x-ray, you can put the sandbag at their elbow to hold their hand still, but you can't put it anywhere near your image because it'll affect that. I went to another conference, and Mr. Browning developed this ball, the Browning ball. So here, look at her. She's like, here, hold this ball. And look how big it is also. So they're reaching up, so that brings the scapula away. The ball is radiolucent. So I just thought that was, and you can do it for chest or abdomen. He was selling them. Anyway, I thought it was interesting. But if they probably can cooperate without having to buy this, and I can't remember how much it costs. Here are those angle blocks. This is the weighted part. This is very heavy. And then you have these big sponges, so you can, again, push these up close to the head and hold still. Notice that they've got the baby wrapped, we call it mummified or wrapped, so that the rest of their body isn't flailing around and moving them. So we've got them wrapped up. I want to show you this now, and then I'll let you go. Notice whoever it is has their lead apron on, and what I want you to notice is how they're holding the baby down. This looks like a pillow or something like that, and then their arm is across the pillow, and she's leaning over using her weight, and that is appropriate. I learned that the hard way. Again, having the patient, I'm going to point to you just because you gave that example, and I've been in that example where my job was to hold the legs, and somebody else's job was to hold that one arm, and somebody else the head, while they do an injection for an IVP. So this is using the shot, and the child is fighting, and it's very critical to hold them still so that they can get the needle in appropriately, right? So I've got the legs. Pediatric patient, I couldn't have been 3, 4, 5, maybe less, and I remember having the legs. Well, and she was struggling, so I'm holding tighter and tighter. She's struggling more and more. We're done. I let go, and I can see my fingerprints in her skin. So, the more she struggled, the tighter I held, and I'm sure the tighter I held, the more I hurt, and the more she struggled. We can't do that. So, if you get a pillow, is a good example, but using your weight and spreading, not all your weight, or using your arm rather than your hands, and helping to hold the patient doesn't hurt them. And that's what's important. You've got to realize what you're doing. You may not be contributing. So it's hard to hold a fighting child. Have you ever had to do that? It's hard. And so just be careful. So we wrap them up to secure their arms and their legs, and then to hold the rest of the body still, because moving the body will move the head. And so she's just gently has a wider area of pressure. And I think that's what's important there. Another pediatric chair, and again, yet another. There's all kinds of devices that can be used. How often do you do pediatric patients in your hospital? Do you do 1 or 2 a day? Maybe none? Okay, well, you can imagine Children's Hospital of LA, Children's Hospital of Orange County, they're doing pediatric patients all day long. They may have all kinds of this stuff at their facility. We may just have 1 Pigastat or 1 Tainment board kind of thing, or 1 infantainer. So you may have to go find it. A lot of times we don't use it. Here again are just the examples of the sandbags. Look at this little thing, how cute. But again, are we doing a chest x-ray? That is pretty close. The baby's weak enough to where, the sandbags will work. So you have to determine based on, you know, assessing your patient and what they're able to do. So this was at one hospital, you know, the sandbags are just those blue vinyl sandbags, and they made some cute little covers in bright colors. This is from a pediatric hospital, so. So we will finish that up next week. We'll do some mummifying next week. Have you ever had to swaddle your baby or wrap them up? When they were kids? Yeah. Yeah, when they were kids.
Yes.
I'm like, what kind of parents are you?
You can
But
teach
when
me
they were
how.
little, you know how you wrap them up real tight?
I will